Good afternoon, ladies and gentlemen. I'm Christopher Lee. Welcome once again to a webinar series on COVID-19 from the ICR at NIH. This webinar is co-organized by the Malaysian Society of Infection Control and Infectious Diseases, MyICID, and the ICR. This week, we have a speaker who is very experienced looking after COVID because he comes from a hot state. Okay, not as hot as Selangor is now, but the previous hot state of Sabah. And he's none other than Dr. Heng. Now, Heng trained with the ID team at Hospital Sungai Buloh in his training years, and subsequently he completed his training in infectious diseases at the National University at Singapore. And of course, I think all of us are familiar with him because he has been integrally involved in the care of patients with COVID-19 in Sabah, especially during the peak last year. Now, last week we spoke about the clinical management of COVID-19, and we talked about the acute management. But I think all of us who have been managing patients with COVID-19 realize that the story doesn't end there. For those patients who survive the infection, many of them face a very complex and convoluted recovery period. I have been helping to look after patients who have recovered from COVID-19 in Hospital Sungai Buloh, and especially those who come out from ICU with categories 4 and 5. They struggle for a very long time during their recovery period. And it's still a very new disease. We have, every few weeks, we hear of something new that might be due to COVID-19. And certain part of the science is fairly well written out, but certain parts of the science is still very new. So we thought it would be a good idea to look at COVID-19 with regards to its complications. And so we have asked Dr. Heng from Queen Elizabeth Hospital in Kota Kinabalu to share with us this very complicated topic. I don't envy him to do this, but we are all in good hands because certainly he has had a lot of experience in the last 1 year. So without further ado, I would like to welcome Dr. Heng from Kota Kinabalu to take over the mic. Heng.
Thank you, Dato' Chris, for the introduction. Welcome to everybody to the webinar.
You got your slides yet, Heng?
Hold on. Can you see the slides? Today, my topic is recognizing the complication of COVID-19. This the hospital that I'm working at the moment, Queen Elizabeth Hospital. So this is the outline of my presentation today. We'll talk about the pathophysiology, and then we'll talk about the clinical spectrum of COVID-19. Then we divide the complication based on acute and the more long-term complication of COVID-19. So in order for us to understand the complication of COVID-19, I thought it's beneficial for us to go back to the basic pathophysiology of COVID-19. So the main purpose of the virus is to enter our cells, hijack it, and then make more new viruses. So what the virus has is the S protein, and what our cells have is the ACE2 receptor. So what happened during the process, the TMPRSS2 will prime the S protein, which subsequently bind to the ACE2 receptor. And once that occurs, the virus will be able to enter the cells, release the RNA, and then use our cells mechanism to produce viruses. But in the process of doing that, the virus actually damage the cells in our body, Actually, many cells in the body, especially the epithelial cells in the upper and lower respiratory tract, contain ACE2 receptors. Not only that, we also have endothelial cells in the blood vessel who also contain many ACE2 receptors. So once the virus invaded the cells, it damaged the cells, it caused inflammation. Our body will recognize the foreign antigens and start to mount an immune response, causing more inflammation, release of cytokines, and ultimately leads to tissue damage, inflammation, exudate, and thickened interstitium if this process is not well controlled. So at the later stage of the disease, we can see there is increased vascular permeability, leading to pulmonary edema, and then there's a thickened interstitium which impaired oxygen to the lungs and the body. And over the right-hand side, we can see the increase in the cytokines leads to activation of the coagulation cascade, and this lead to microthrombus formation and pulmonary embolism as well. So what are the phases of COVID-19? So this not to be confused with the staging of severity. During the initial phase, stage 1, there's a viral response. And then if the disease continues, then the patient progresses into stage 2, which is the pulmonary phase. And if the disease is not controlled and the inflammatory process continues, then it can lead to a very dangerous stage, stage 3, which is called hyperinflammation. And during that time, our patient can have ARDS, shock, and cardiac failure. So over the right-hand side, there's a clinical syndrome called MIS-C and MIS-A, which usually occur during the late stage of the disease. So multisystem inflammatory syndrome in children and adults. So very important for us as clinicians, whenever we see a patient, to try to visualize and imagine where our patients are headed at that point, because we can predict many of the clinical manifestation and complication based on the phase of the disease. And treatment is also initiated based on the staging of the patient as well. So what are the clinical spectrum of COVID-19? About 40 to 50% of the patients are asymptomatic. It could be higher, depends on the study that we are looking at. About half of these asymptomatic patients are truly asymptomatic. That means they remain truly asymptomatic throughout the course of the disease. About half of these patients are pre-symptomatic. Basically, they can develop symptoms after initial diagnosis by PCR or RTK antigen. So usually this type of patient are picked up during contact screening or travel screening, and later, after 2 to 3 days, they develop symptoms. But the most important thing about asymptomatic infection is people without symptoms can still have clinical abnormality, as evidenced by abnormal CT scans. This is a study published back in the early phase of the pandemic in China, where they performed CT scan in 58 asymptomatic patients, and they found that 94.8% of the patient has ground glass opacity, and 30% of the patients subsequently develop symptoms. So meaning 70% of the patient remain asymptomatic, and yet they have ground glass opacity in the CT scan. How about the rest of the patients who are symptomatic? So this is another study from China looking at 44,000 individuals with confirmed COVID-19. So 81% of the patients will have mild symptom, 14% develop severe symptom, and 5% develop critical illness. So most of the time, patients who develop complication will belong to this category of severe and critical illness. So who are the patients who might go into severe COVID-19 disease? Usually they are older patients, people of any age with a concurrent medical condition such as obesity, diabetes, hypertension, cardiovascular disease, chronic kidney disease, chronic lung disease, and malignancy. This is a study published in UK following a cohort of patients. So they found that using multivariate survival analysis, as the patient age increases, the risk of mortality increases as well. So it's nicely shown here. And patient with underlying comorbidity has increased risk of mortality as well, including being a man as well. So what are the manifestations of severe COVID-19? The most common manifestation will be hyperinflammatory phase, leading to acute respiratory distress syndrome, cardiac complications such as acute cardiac injury, myocarditis, arrhythmias, and cardiomyopathy. And one of the peculiar complications of severe COVID-19 involve thromboembolic complication. So many of our patients develop pulmonary embolism, stroke, even venous or arterial thrombosis. Then there are other target organ injury such as acute kidney injury, liver injury, neurological complication, and then an immune complication termed as multisystem inflammatory syndrome in children and adults. So this diagram summarizes the extrapulmonary manifestation of COVID-19. So in addition to cardiac, neurology, thromboembolic, hepatic, and renal injury, there are also endocrine complications. So especially nowadays, we are using steroid to treat stage 4 and 5 patients. We are seeing a lot of endocrine complications. I'm going to illustrate some of these complications by sharing with you some of the case studies that we encounter in our hospital. So the first case is a 27-year-old male with no known medical illness. His BMI is 28. He presented with a history of fever, dry cough, diarrhea 2 times a day, feeling really tired, and with reduced appetite for 5 days. PCR was detected 2 days later, and we diagnosed him as COVID-19 stage 3 because of the chest X-ray report. So this is a summary of the investigation done on our patient. So upon admission on day 5 of illness, he was started on favipiravir because of the X-ray changes. He has fever, but vital sign was normal otherwise. So you can see the most abnormal result on day 5 of illness was the CRP, which was 15 milligram per liter, which is 3 times the upper range of normal. So as the day goes by and the week go by, he has persistent fever on a daily basis, and we can see his CRP slowly climbing up and lymphocyte reducing. So that time, since it was day 5, I put him at the viral phase of the illness, but we know it's going to the end of the week, so we are watching him very closely. In view of the increasing CRP, we predict he might be going into inflammatory phase or hyperinflammatory phase the following week. So we're watching him very closely over the weekend. 29th of November was Sunday, so it went up to 53.7. So my comfort zone when I look at CRP was 50 milligram per liter. So beyond that, I usually will become quite uncomfortable because some of our patients develop hypoxemia when the CRP reach 30. So to reach 50, usually I'll be quite worried. However, I couldn't find any indication to start on dexamethasone because there was no hypoxemia. He was not tachypneic. We even did the exercise test and there was no desaturation as well. On the following day, which was day 10, when I saw him, he just came back from the washroom. So he was tachypneic, respiratory rate was 26 and saturation was 94% on air. So I know he already reached stage 4. So we decided to start him on IV dexamethasone. So the CRP came back later, which show a level of 90 milligram per liter. So after started dexamethasone, he improved. CRP came down progressively over the next few days, and he recovered. So at the same time, when the CRP went up, you can see the LDH and ferritin also went up together. So this is a serial chest X-ray performed on our patient. So this was on the day 5 of illness. And then 5 days later, you can see infiltration over the left side of the lungs. There was many questions asked why it was more towards the left side of the lungs. So one of the reasons is because our patient always lie on the left-hand side because the right-hand side was the corridor. So there was not much turning position being done. So, and when we took the X-ray, we can see the dependent area has more changes compared to the right-hand side. And after the dexamethasone was started, he recovered, fever lies, CRP came down. We managed to wean off oxygen a few days later, and immediately after we started on dexamethasone, he became more energetic. He talked more, appetite recovered. We can actually predict that he's getting better just by looking and talking to him. Okay, this is case number 2, a 55-year-old lady with no known medical illness. She was admitted during the end of the first week of November at our hospital for stage 3 COVID-19. PCR was positive 2 days before that. However, she was asymptomatic. Stage 3 was diagnosed purely because of the chest X-ray report, and she was on room air throughout admission. She was very well discharged on day 11 after 10 days isolation with no complication. However, on day 5 after discharge, she started having fever associated with loss of appetite and coughing for 3 days with productive whitish sputum and diarrhea for 3 to 4 episodes per day. And because of the symptoms, she went to the private hospital and they repeated the PCR and it was positive, so that they referred back to us. So on arrival, she has a temperature of 38. She was tachypneic. The saturation now was 94% on air. And the most important finding was the CRP. It went up to 65.6. So this is the serial investigation. You can see the CRP. The first 2 columns was when she was admitted during the first time. You can see the CRP was monitored. She was actually monitored for 3 times, and the CRP were normal during the first admission. But during the second admission on day 21, from the diagnosis of the COVID-19, you can see the CRP went up to 65.6%. Patient had fever, she was tachypneic, she needed oxygen. So we started her on dexamethasone 6 milligram OD, and gradually we managed to wean off oxygen 2 days later, and the inflammatory marker continued to recover and normalize towards the end of the hospitalization. So these are the serial chest X-ray of the patient. You can see during the second admission, there are more infiltration over the lower lobes. Case number 3, a 45-year-old lady with underlying left hemithyroidectomy for thyroid nodules. And she had a BMI of 36, presented with fever for 1 week since the end of December, and cough for 2 days, anosmia for 3 days, and diarrhea for 1 day. She was admitted to the district hospital where they did an expert SARS-CoV-2 test, and it was positive. That time there was desaturation, so they categorized her as stage 4 COVID-19 and started on dexamethasone 6 milligram daily. The lymphocyte count was 1.8, CRP 23.5. So the CRP was not too high. And she was started on dexamethasone and favipiravir because she was stage 4 and needed oxygen. However, on day 10 of illness, she desaturated and needed high flow nasal cannula, and she was transferred to our hospital. So this is the baseline chest x-ray, and this was on day 10 of illness. 5 days later, you can see the increasing in infiltration, which caused hypoxemia. CT scan was done, showing a multifocal consolidation at the peripheral and dependent area with crazy paving, suggestive of organizing pneumonia. So this is the summary of the serial investigation. You can see on the day of admission, the CRP was 23, then it went up to 45 when she needed high flow nasal cannula, and she was given pulse methylprednisolone, and then subsequently it came down to normal. So the patient is still in our ward. And she's improving. These are the X-ray after the pulse methylprednisolone. Case number 4, another young patient, 36-year-old gentleman with history of dyslipidemia and overweight, was diagnosed as stage 1 COVID-19 on the 4th of October. He completed 10 days isolation at the low-risk isolation and quarantine center, was discharged well. CRP was normal, 3.7. A month later, he came with chest pain, sudden onset of chest pain while driving. That was on the day 32 from the diagnosis of COVID-19. So he went to the private hospital. He was pain-free upon arrival. The private physician noted some ECG changes and elevated troponin I. So he was referred to the cardiologist. They did echocardiogram. The LV function was preserved. They even did an angiogram showing mild disease at the distal left circumflex artery. Since the patient was pain-free, they planned for medical therapy and they admitted the patient for observation. Unfortunately, 2 days later, the pain recurred. Then they did a relook chorus. Similar finding, no angioplasty was performed to the patient. He developed hypotension during the procedure, needing dopamine 5 mics. Then they noted the cardiac enzyme increase. So they decided to do more further tests. So you can see the serial cardiac enzyme troponin T from 430 went up to 2000. And there's also increment in creatinine kinase, AST, and LDH as well. The CRP was normal. The inflammatory markers normal. Ferritin was normal. They repeated the PCR panel for the patient. It was normal. There was no SARS-CoV-2 detected in the patient. So they even did a CT thorax for the patient. So they found bilateral posterior basal fibrosis. So this is a stage 1 patient who was discharged well, and yet a month later, CT scan was done showing basal fibrosis in the lung. So because of the chest pain, they did a cardiac MRI for the patient, and there was extensive subepicardial fibrosis. And there's also ongoing myocardial edema in the basal to mid-septal and inferior wall, and also pericarditis at the lateral wall as well. So the overall impression is acute or subacute, acute with subacute myocarditis in the patient who had recent COVID-19. So patient was started on dexamethasone, and the symptom resolved, and he's currently well. So myocarditis in COVID-19 patient has been reported. So you can see this is a study published by German investigator. So looking at 100 COVID-19 patients who recovered from the illness. And when they did cardiac MRI in the patient, they found that surprisingly 78% of the patient has cardiac involvement. And 60% of this patient has ongoing myocardial inflammation. Another study done in very young athletes, competitive athletes, 26 athletes. So they found that 12 of these patients reported mild symptoms. That means another half has no symptom as well. So this patient has no symptom or very mild symptoms, but they do not have any ECG changes. The echo finding was normal. The cardiac enzyme was normal. And when they did cardiac MRI in this patient, they found 4 of the athletes has cardiac MRI findings consistent with myocarditis, and 2 of them has pericardial effusion as well. So the take-home message from this is, even though patients have mild disease or asymptomatic disease, they can still have myocarditis or ground glass opacity in the lungs, as demonstrated by earlier study as well. So case number 5, 81-year-old lady with background history of diabetes and hypertension presented with fever and dry cough for 2 days at the district hospital. She was admitted on day 2, however, deteriorated on day 16 and was intubated. CRP went up to 123. She was started on IV methylprednisolone. So because of the difficulty in winning oxygen and there was persistent tachycardia, and echocardiogram show right strain pattern, and in addition to that, patient also had raised D-dimer as well. So they suspect a pulmonary embolism, and CTPA show a filling defect in the left descending artery, confirming pulmonary embolism. This is another young patient, 47-year-old female, a school clerk in the district hospital, background history of diabetes and macrovascular complication of stroke. She was on basal bolus of insulin, aspirin, and statin. So she was initially admitted to the low-risk quarantine center. Then she had difficulty in breathing and was escalated back to the hospital there. Unfortunately, she needed high-flow nasal cannula and was subsequently ventilated as well. So you can see the CRP went up to 205, and she was started on methylprednisolone as well. And you can see she responded very well to the methylprednisolone. However, the D-dimer suddenly shot up to 35, and we decided to do a CTPA for her, which showed acute pulmonary embolism. She was started on anticoagulation, full dose anticoagulation, and she subsequently improved and currently on room air as well. So this is the CT finding showing acute pulmonary embolism in the right middle lobe pulmonary artery and segmental branches of both upper and lower lobes pulmonary arteries. So now we move on to discuss about COVID-19 coagulopathy. So during the early phase of COVID-19 pandemic in China, the investigator there has noted a very high prevalence of thromboembolic complication there. Subsequently, when the pandemic spread to Europe, they also found similar findings. So when we look at all these cohort study of ICU patients, you can see there's a range of reported VTE rate ranging from 11.7 up to 69%. And in China, because they started first, thromboprophylaxis was not started. But even when thromboprophylaxis was started later, you can see the rate of thromboembolic complication was still ranging from 11 to 69%. These are ICU type of patient. So compared to historical control of pulmonary embolism in ARDS patient, you can see in this French study, it was much higher compared to historical control of 2.1%. So when they compare ICU versus non-ICU COVID-19 patient, you can see the ICU patient has much higher risk of thromboembolic complication, which was 20.6 versus 6.1. So meta-analysis done show that the pool estimate of DVT was 16%, higher in China compared to Western country, and higher in ICU population at 23% versus non-ICU patient at 5%. Another meta-analysis done in COVID-19 patient with pulmonary embolism also show the incidence of about 15.3%. So roughly about 15 to 20%. The other finding about this meta-analysis was the mortality is very high in this meta-analysis, up to 45.1% compared to 4% in historical control. So pulmonary embolism is common, especially in ICU population, and carry a high mortality. In autopsy study of lung damage in COVID-19, from this cohort of patients, 7 of 12 patients had unsuspected bilateral DVT, and 4 of them died from pulmonary embolism, meaning from this study, many of the cases might go undetected without post-mortem study. So what is the underlying pathophysiology of thromboembolic complication? The central feature postulated is thought to be due to endothelitis. So what happened was, as we know, our endothelial cells in the blood vessel has many ACE2 receptor. So the virus can bind to the receptor, causing inflammation. So if you look back at Virchow's triad, there are 3 important components predisposing our patient to get thromboembolic complication. So the first one, as we have discussed just now, is vascular endothelitis leading to endothelial dysfunction. Then the second one is venous stasis. The third component is hypercoagulopathy. So this is a very nice diagram illustrating the process of thromboembolic thrombosis complication. So the virus binds to the ACE2 receptor in the endothelial cells, leading to systemic and vascular inflammation. The process produces fibrinogen, interleukin-6, CRP, factor 5, factor 8, and von Willebrand factor. All this leads to hypercoagulopathy, and lead to deep vein thrombosis. At the same time, the viral invasion activates the immune system, leading to endothelial cells inflammation and injury, and this predispose patient to get thrombosis as well. So the third component is venous stasis. This can be due to sludge or immobility, and altogether, all these factors leads to deep vein thrombosis. That's why patient with COVID-19 has higher risk of thrombosis. There are laboratory predictors of thrombosis, as we have seen before. These are fibrinogen, CRP, ferritin, and D-dimer as well. So that's why the guidance on thromboprophylaxis is to start a patient who are hospitalized with a prophylactic dose of anticoagulation. In our guideline, we recommend starting a thromboprophylaxis in stage 4 and stage 5 patients. These are Western country recommendation. They don't admit a symptomatic patient to hospital. So those admitted to their hospital are those patients with severe and critical illness. So now we move towards a neurological complication. So the first question that we want to ask ourselves is COVID-19 neuroinvasive? So we have seen from early discussion, our respiratory airways contain many cells which have ACE2 receptor. So are there any ACE2 receptor in the central nervous system? Yes. Most of the ACE2 receptor are in the motor cortex, areas around the ventricles, the ventrolateral part of the medulla, and olfactory bulb as well. In fact, many of the neuron cells, microglia, astrocytes, oligodendrocytes has ACE2 receptor. So potentially this area can be can be attacked by the virus if they manage to reach the central nervous system. So there are two main hypotheses on how the virus can spread to the brain. So the first one through the vascular system. As we know, the brain has blood supply, so the virus can travel through the blood vessels. It can infect the endothelial cells, causing endothelial injury and disruption of the blood-brain barrier. And then some of the infected white blood cell can go through the blood-brain barrier to the brain as well. So the other mechanism is through the olfactory epithelium. So epithelial cells has many ACE2 receptor. So from there, it can infect the olfactory nerve, and then through a retrograde spread, it can travel from the olfactory epithelium to the olfactory bulb as well. And from there, it might spread to the brain. So these are the hypotheses of how things might happen. So the next question is, can viral invasion cause meningitis and encephalitis? Then we will go through other complication of central nervous system infection, especially hypoxic brain damage, thromboembolic complication like stroke, and neurological autoimmune disorders. So first, let's discuss about viral invasion. So as we discussed just now, central nervous system contain many ACE2 receptor. So anosmia is a very common presentation of COVID-19, up to 10%, even higher in some case series. So the question is anosmia caused by mucosa infection or nerve involvement? So the second thing is encephalitis common? So there are very few case report of encephalitis. I think less than 10 reported. Most of the time, the CSF finding was normal. Very few has positive PCR. So from the case report, it seems that encephalitis and meningitis are quite rare in COVID-19 patients. When they look at post-mortem study, looking at the concentration of virus in the brain, they found that the highest concentration of virus is actually in the mucosa, olfactory mucosa. So very few of the specimen contain virus. There are only 3 patients with virus detected in the olfactory bulb. So another post-mortem study done show 18 of the patient only showing hypoxic brain damage. There was no sign of encephalitis. There was no sign of cytoplasmic viral staining in the specimen. And there are very few virus detected in 5 patients. And the hypothesis was the virus was actually in the brain from the blood rather than causing inflammation in the brain. How about stroke? Up to 5% of hospitalized patients develop stroke. These are published by the Chinese investigator. So the same mechanism that caused thrombosis is hypothesized to occur in stroke patients. So because of the vascular endothelial dysfunction and coagulopathy, these patients are predisposed to develop stroke. Usually these are large vessel thrombosis. Many stroke patients has infarction of the lungs, kidneys, and brain as well. There's also another entity called critical illness associated microbleeds. So especially in ICU patient who has reduced in GCS or has prolonged coma. So this patient have microbleeds in the brain because of hypoxia and microangiopathy causing diffuse damage to the brain. And the prognosis is not good. Usually patient will have cognitive impairment and disability. It's very difficult to diagnose. You need a MRI susceptibility weighted imaging to see it's not picked up by T1 or T2 imaging. Then the other complication involving the central nervous system and the peripheral nervous system is autoimmune disorder. There are small studies and case report published regarding Guillain-Barré syndrome, transverse myelitis, edema, and acute necrotizing encephalopathy. So there are still a lot of things that we don't know about central nervous system complication. Professor Tom Solomon has summarized what we know so far in January. Anosmia, encephalopathy, and stroke are the most common neurological syndrome associated with COVID-19. Biopsy sample suggests anosmia result predominantly from infection of the non-neuronal cells in olfactory epithelium and olfactory bulb. And a high proportion of patients admitted to ICU develop delirium. And evidence to date suggests this is caused by microvascular and inflammatory complication. There is not much evidence to suggest there's encephalitis. The virus can cause encephalitis. So even though the virus can be detected in the brain with PCR, but the evidence to date suggests it is mostly come from vasculars and also immune cells rather than caused by direct infection of the neurons. Okay, I'm going to talk about multisystem inflammatory syndrome in children and adults. This is a very rare complication of COVID-19. During the beginning of the presentation, I put a note of this syndrome at the end of the hyperinflammatory phase because that's what was thought to happen. So during the pandemic in New York City, they noticed after a surge of cases of COVID-19 patient, about 2 to 4 weeks after that, they noticed this sudden surge of ill children coming to their hospital with multi-system involvement, shock, and some mimics Kawasaki syndrome. So MIS-C now has become a recognized syndrome, was first reported as hyperinflammatory syndrome with variable features of Kawasaki disease. So CDC has coined a case definition for MIS-C. This is the case definition of MIS-C. Any individual aged less than 21 presenting with fever, laboratory evidence of inflammation, and evidence of clinically severe disease needing hospitalization with multi-system organ involvement, and other diagnosis has been ruled out. And there's evidence of recent SARS-CoV-2 infection within 4 weeks prior to onset of symptoms. So this is a syndrome characterized by hyperinflammation. Most cases occur several weeks after the confirmation of SARS-CoV-2. In fact, many children has no diagnosis of COVID-19 before, and they only can diagnose it retrospectively using antibody tests. So it's characterized by fever, markedly elevated inflammatory biomarkers, and multi-organ system involvement, frequently with prominent GI symptoms. It is also characterized by shock and cardiac injury, typically involving elevated cardiac biomarkers, left ventricular dysfunction, coronary dilatation, and often they need inotropic supports. So this is very important for us because in Malaysia, adult medicine take care of patients from age 12 onwards, you see. So we might be seeing some of these patients coming with MIS-C. At the same time, there are case series of adult patients being reported as well, mimicking the similar syndrome in children. Often these patients came with multi-organ dysfunction, especially cardiac dysfunction, needing inotropes after the initial diagnosis of COVID-19. So we need to be aware of this MISC and MISA. Often when they did cardiac MRI, patient has myocarditis in this patient. So now I'm going to the final section of the presentation. We are going to talk about the long-term complication of COVID-19. So there are many studies been published at the moment. There are evolving definition of what is considered post-COVID syndrome. This is from the British group, defined as symptoms present for more than 12 weeks with no alternative diagnosis. So these are studies published looking at patients who are discharged and were at day 14 to day 21 of illness, day 14 to 21 days of diagnosis. You can see most of the patients still having profound fatigue, cough, loss of taste and smell, dyspnea, chest pain, abdominal pain, and confusion, which some reported as brain fog. Going to 1 to 2 months after discharge, you can see many patients still experience fatigue and breathlessness, and some experience post-traumatic stress disorder as well. And anxiety and depression seems to be common as well, including concentration problems, musculoskeletal and rheumatology pain. So we can see more patients reported fatigue, breathlessness, and psychological distress in the ICU group especially. Going to 2 months of discharge, you can see many patients still experience fatigue and dyspnea. Only about 12.6% of patients were completely free of symptoms. So 55% had 3 or more symptoms. So you can see even after 2 months after discharge, some patient has significant symptoms even 2 months after discharge. And most of them, half of them, reported worsening quality of life compared to before infection. So this is not unknown in coronavirus infection. Looking at SARS epidemic back in 2001, you can see this is like ranging from 13 to 36 months following SARS infection. Many survivors of patients, many including healthcare workers in Toronto, continue to experience significant musculoskeletal pain, fatigue, depression, and sleep disorder 13 to 36 months after discharge. This is another study looking at 1 year outcomes of SARS survival. So you can see 1 year after discharge, majority of the SARS survivor has normal pulmonary function, and yet 18% of them experience significant reduction in distance walk in 6 minutes. And 17% had not returned to work by 1 year. And many pay visit to psychiatry and psychology practitioner. Not only patient, even their caregiver reported decline in the mental component score. So from this study, we know that most SARS survivors, even though they have good physical recovery, but some patients and their caregiver reported a significant reduction in mental health even 1 year later from the infection. How about long-term data from SARS infection? We don't have long-term data for SARS-CoV infection at the moment, but looking at SARS-CoV-1 infection, this is a 15-year follow-up of lung and bone outcomes. You can see pulmonary damage and function decline, mostly recovered by then, especially the greatest recovery occurred within 2 years of rehabilitation. Femoral head necrosis induced by large doses of pulse steroid are usually not progressive and partially reversible. Then there's this post-ICU syndrome. which occur in ICU patient. This can last beyond ICU hospitalization as long as 5 to 15 years. And those patients at risk of post-ICU syndrome has sepsis, delirium, prolonged mechanical ventilation, and multi-organ failure. There are many combination of pulmonary issue, physical disability, and psychological impacts in this patient. So meaning being admitted to ICU come with a potential long-term complication. So the take-home message from my presentation, we know now there are many range of clinical manifestation and complication of COVID-19. Some go beyond hospital discharge, some last even longer than 3 to 6 months. We know from SARS-CoV-1 infection, it can last many years. From a clinician point of view, when we see a patient with COVID-19, we need to correlate the clinical findings with the phase of disease and the stage of illness to determine the next step of treatment. The third take-home message from me, for asymptomatic and mild cases, even though they are well, they can represent later during the hyperinflammatory phase, especially when we look at the multi-system inflammatory syndrome of children and adults. And finally, we need to look out for post-COVID syndrome, and we need program for this group of patients, which need to involve rehabilitation, psychiatry, and from our perspective, we need to involve our family medicine physician as well in the development of these post-COVID treatment programs. With that, I would like to thank all of you for joining the webinar today.
Thank you very much. Thank you very much, Heng. You had a lot to cover. I appreciate all the time you have taken to try to be as complete as possible, but it's not possible. We cannot talk for 5 hours, obviously. Thank you very much. Now, there are a lot of questions we need to go through, but I would remind everyone that last week we had a presentation from Dr. Yasmin, and she had covered some of the complications that Dr. Lee spoke about. Obviously, the hyperinflammatory part or phase of the infection, especially pulmonary findings. So perhaps we will try to focus on the other complications rather than repeat the same one. Having said that, next week there will be a webinar focusing on the care of COVID-19 in the critical care setting. So once again, some same issues might come up. So based on these webinars before and after Dr. Lee's, I will try to focus on topics that may not be covered by the other speakers. So I ask all those who have asked questions to bear with me because we're trying to cover as much as possible. So Heng, are you ready? All right. Okay, come, let's start. The first question I can see is, I think, linked to the issue of anticoagulation. I think we all know that there's a key part of our management, especially for our patients in category 4 and 5. The question is, how long do we continue anticoagulation if there's no evidence of PE, but the D-dimer remains high?
The recommendation say we start anticoagulation in stage 4 and 5 patient, meaning patient who needs oxygen. Of course, people with added risk factor of immobilization, we also start thromboprophylaxis for them. So when we look at guidelines from NIH, they also say any hospitalized patient should be started on thromboprophylaxis. So that is the standard of care. So when we go back and look at this question, how long do we continue anticoagulation if there's no evidence of PE, but D-dimer was high? So I think we need to revisit and assess the patient and trying to find out why the patient has a very high D-dimer or high D-dimer. So there are many causes of raised D-dimer. Thromboembolism, thrombosis is part of it. Sepsis can also cause raised D-dimer, even pregnancy. Trauma can cause raised D-dimer. So there are many differential diagnoses for D-dimer. So if the D-dimer is high in a well patient, I would want to revisit the patient, examine the patient to see whether there's other causes of raised D-dimer. So for a very ill patient, then I think the approach will be slightly different. It really depends on whether patient needs ventilation, mechanical ventilation. So even though the pulmonary embolism is not shown in the CT, I think it's good to always have a discussion with the radiologist to see, have another reassessment, look at other area where thrombosis can occur as well, especially DVT, thrombosis of the catheter and things like that. Yeah.
Yeah, I agree with you, Heng. I think obviously we need to correlate with the clinical findings and the clinical situation of the patient, and we shouldn't just look at the D-dimer by itself. A follow-up question would be linked to also anticoagulation. This question is it common to see isolated coagulopathy in COVID-19 patients? I presume the person who's asking is talking about patients with COVID-19 who are otherwise don't have other complications, but just coagulopathy alone. So do we often see that?
I think it's quite rare. So if we look at the literature, so ICU patients generally they have a prevalence of 15 to 20% incidence of thrombosis. So for non-ICU patients, that's about 5%. So these are hospitalized patients in Western country, meaning at least they are admitted because of severe disease or probably underlying comorbidity. So if we are talking about maybe stage 1 or 2, I think that the risk of thrombosis is pretty low. So, but I'm not aware of a study, definitely I'm not seeing any of my patients who are well with isolated thrombosis.
Yeah, I think the experience is fairly similar in other places as well. Certainly in my limited experience looking at post-COVID cases, most of the patients with coagulopathies tend to be patients who are much more ill, patients in category 4 and 5, and obviously with other complications linked it as well. So I guess if the patient is otherwise well, the risk of coagulopathy drops significantly. Now, I'm going to move on to another area which we don't talk enough about, but for many patients who come in with a pneumonia with COVID-19, especially if they are in category 4 and 5, we frequently see physicians putting empirical use of antibiotics at the same time. And obviously, everyone wants to cover for bacterial sepsis in the patient who's very ill. I understand that, but obviously we are also concerned about things like antimicrobial resistance. The question here specifically is looking at, is staph pneumonia common in post-COVID infections? So perhaps, Heng, you'd like to talk a little bit about the infections, the concurrent infections that you see in managing COVID patients.
Yeah, there are quite a number of publications been published about this. Generally, for non-ICU patients, the incidence of concurrent bacterial infection range from about 7 to 8%. So it's not high. So in ICU patient, that's probably double, to 14%. But compared to other viral infection, generally the incidence of concurrent bacterial infection is low in COVID-19. So we are quite fortunate here in our hospital. We have a ProCal. So many of our patients who progress to stage 4, stage 5, when we did the ProCal, they are most of the time it came back as very low, 0.01 or something like that. and the blood culture and the septic the culture are all normal. So I'm quite confident the rate published does mimic the true incidence of concurrent bacterial infection in COVID-19 patient. It's pretty low.
Right. So as I mentioned earlier, I think I can understand why people start empirical antibiotics when the patient comes in very ill at the outset. However, I think it's important if we do that, I think once the results come in, and if you are procalcitonin, I think over the next few days, I think we all should de-escalate as fast as we can, if possible. So thank you, Heng, on that score. I'm going to move to another area of management about steroids, because that's one of the key areas of intervention that we have now in the care of COVID-19. Two questions on steroids. First question is, how do you manage oxygen-dependent patients who are still dependent on oxygen for more than 1 month, despite having tapered DEXA in the post-COVID-19 DEXA, or tapering prednisolone, you mean, despite tapering prednisolone in the post-COVID stage 5 cases?
We are seeing more and more patients who has this complication. So many of them develop organizing pneumonia. Some of them has lung fibrosis as well. So usually during the initial phase, we try to prevent patient progressing to this stage of hyperinflammation, because when it does occur, then there's a chance that our patient will develop lung fibrosis, and it can become irreversible. So when it comes to about a month and patients still needing oxygen, even before that, we actually get our respiratory team to be involved. We do have multidisciplinary team managing this group of patients. So in terms of inflammation, as much as possible, we taper steroid based on the inflammatory markers. We want to reverse the inflammatory process. Then there's a chance for the patient to have a good recovery and rehabilitation. So to shorten the answer, I consult our respiratory physician a lot during this stage of the illness because they need a lot of assessment.
Right. Thanks, Heng. I'm going to take on the last question because time is running out, and I think this is an important question. We have had thousands of patients with COVID going through our system in the last 1 year. With all the complications that you've spoken about, some already fairly well established, some still very much in the very woolly stage of understanding. How are we following up all these post-COVID patients? What is the follow-up plan for this?
Yeah, I think the ideal situation will be a dedicated program where patients are seen, by a specialized team who gain experience, by seeing the patient and following them through. So overseas, they have a post-COVID clinic, which is good. They have program, they have guideline. So, but looking at, local situation, for example, in my center here, we are already coming to the 6 month of the, the pandemic in Kota Kinabalu. So most of our manpower are actually exhausted in the hospital. So, so we rely a lot on our family medicine specialists to coordinate the post-COVID care. So they have published a local guideline, with other discipline as well, especially rehabilitation, the respiratory physician, psychiatrist, and the cardiologist. So this is going to be a multidisciplinary approach involving everybody who are involved in COVID-19 care. So I think, what is ideal, and what we can do at our local level does determine what is the best for the program at that time, you see. So I hope the level of cases will come down and I can continue to run my post-COVID clinic.
I wish that for you too, Heng, for the cases to come down. I think we wish that for the whole country. such quickly, just to summarize your last answer. Ideally, I think as we have decentralized our COVID care, that many hospitals now look after COVID, including private hospitals. I think that local hospitals should provide the follow-up, and whether there's one specialized team looking after them, because all this data needs to be collected, and we're still unsure how some of these complications will pan out. Clearly, I think the people who are very involved in the post-care of COVID are the respiratory physicians, neurologists, and cardiologists to some degree. But I think more and more doctors, generalists will have to provide post-COVID care as well, because I think looking at what Heng has told us, I think the list of complications, not just the acute, but even those more chronic complications can be actually continue to grow over time as we understand this disease better. So with that, Heng, thank you very much for your presentation. Thank you very much for being very clear and concise, as concise as you could be in a very huge topic that they have given you. So if you are a bit upset with the topic, please call Dr. Anusha to send in your complaints. But we appreciate your time and effort for putting this talk together. So Heng, thank you very much. And I'd like to thank once again the co-organizers, my ICID as well as ICR, for putting this together, the secretariat here, the ladies who have been running the show, doing an excellent job behind the scenes. So before we depart, I just want to give some housekeeping. The slides from Dr. Heng, a slide set will come out by tomorrow in our website. You can look for it there. And next week, we have the third of our series, and this will look at the care of COVID-19 in the critical care setting. So for all of you intensivists or intensivist wannabe, I urge you to come on board next Wednesday. So with that, I thank Heng once again and everyone else for tuning in this afternoon. Thank you very much and have a safe week, and happy Chinese New Year for those who are celebrating. We can all save on ang paos this week. Of course, you can transfer money, but we'll try to save money. Thank you very much, everyone. Goodbye.
Okay, thank you, Dato. Thank you, everybody.